Selanjutnya kepada Dr. Hewan Eko Prasetyo, waktu dan tempat disilakan.
Okay, thank you very much for the time given to me. I would like to say thank you so much for Companion Animal Health who support us to for having this webinar, and also for Anita Kwok and also Stephen Chang who always supporting us to do many webinars in the next futures. And then for the second one, I also want to thank you so much for Dr. James for the support, for the timing, and also sharing experience about osteoarthritis, because this is become one of the most important things that we know that talking about pain management, it will become one of the most important that we have to monitor, and that's why we invite Dr. James on this special webinar. And also, not only Dr. Jane, we have Emily, but we will try to divide into two sessions. In the first session, we will discuss more about osteoarthritis. I just want to confirm to you guys that thank you so much for all vets for joining these programs. Of course, this program supported by Cahyono Mulyo Sampurno. And then tonight, actually, we have special programs to give new insights, maybe setting sessions from Dr. Jens talking about non-invasive pain management. And of course, I would like to say thank you so much for all of you guys, for all the participants who have joined this webinar. Not only come from Indonesia, but also I hear from Anita Kwok, and there are many veterinarian comes from India. So this is, I think this has become one of the most important that we can share this webinar to veterinarian, not only in Indonesia, but also in other countries. Well, let's move to the next webinar. We have special guest speaker tonight. We have Dr. Jane McNae. Good night, Dr. Jane. How are you today?
Hello. Can you hear me okay?
Yes, I can hear your voice clearly. So
Fantastic.
actually, we hope that we can invite you come to Indonesia in the next offline seminar actually. But now for just warming up, we can learn many things from you. And I would like to introduce you first. So Dr. Jane McNae is a veterinary surgeon and physical therapist and the owner of Paws in Motion's Veterinary Physiotherapy and Pain Management Center in Hong Kong. So actually, not only in expertise, not only in treating pets with musculoskeletal and neurological problems, but also including post-surgery recovery, and has over 25 years experience, global experience. Dr. James also an educator and holds dual membership in small animal veterinary sport medicines rehabilitations from Australians and New Zealand College of Veterinary Scientists. So guys, let's move to the first presentations for Dr. Jane. Screen and time is yours.
Okay, let's see. Has my screen shared? Yes, there we go. Fantastic.
Yes.
Let me just open up my presentation again and we'll get going. So thank you very much, Echo, for that introduction. And maybe just remind everybody to make sure your mic is on mute unless you have a question. That would be fantastic. So yes, I'm Jane McNae. I'm speaking to you tonight from Hong Kong. Only a little bit ahead of your time, so we're on the same time zone here. And I do want to go through some components of rehabilitation, but osteoarthritis is such a key part of that. So let's hop in. I've got a few slides to remind you about what we're going to cover tonight. So first of all, we're going to go through the non-invasive pain management modalities, and I've got 4 that I want to take you through. Then we're going to look at how we integrate and combine those modalities in practice. So this is looking at real cases, and I've selected some that hopefully you're pretty familiar with: multi-joint osteoarthritis, but also cruciate ligament disease. I don't have a medial patella case, but they're very similar to cruciate ligament, and femoral head and neck excision, muscle contracture, and then some chronic osteoarthritis. So that's what we're going to cover. But just to make sure we're all talking about the same thing, first of all, let me just revise with you about osteoarthritis. So what we know in dogs is that actually osteoarthritis is a young dog disease. 1 in 5 dogs at the age of 1 are already suffering from osteoarthritis. And by the time they're at 8 years of age, this is 80%. So it's a really high proportion of cases that we see. And this is different to humans. In humans, it's 1 in 5 humans, but most of those are over the age of 55. So we're not so much worried about age being a disease, but just we know that older pets are more prone to problems. Okay, so this might bring you back to university and make you feel a bit nauseous. It certainly makes me nauseous. But just a reminder that when we're talking about pain, we need to think about the whole pain pathway. So not only where the pain occurs, the transduction, but the transmission of that up towards the spinal cord, the modulation, and then the perception in the brain of that pain signal. When we're talking about animals, in particular those with osteoarthritis, we're talking about a type of pain that's known as maladaptive pain. So maladaptive pain is not useful. It's not well controlled, and it generally causes altered pain limits in the pet patient, and that decreases the quality of life. So other types of pain like nociceptive pain, inflammatory pain, or nerve pain, these are involved to stop the body doing something. So they're important, but when we get to this chronic maladaptive pain, it's not useful to our pets. So this is what we're talking about this evening. This is just a flow on from that. You'll be familiar with many of the different medications that you have available. They work on different parts of the pain pathway. So what I want to show you tonight is how our modalities can also work on those parts of the pain pathways. Okay, I'm going to do that by showing you a couple of cases. So just a little taster. We're going to look shortly at Charlie, who's a 9-year-old Labrador. When I meet them the first time, I always take videos of how they're walking, generally in slow motion, so that I can start to see different things. And in this doggy, I can see that he is slightly dragging his left back foot. His nails come close to the ground, which matches what the owner told me as well. And he looks very stiff at his back end, and he's a little bit fat. I'm going to show you how we get Charlie through to this happy version where he can run out and sit and stand, all by using different modalities or machines. Okay, so how do I explain this to the client? Well, that involves getting the client on board with what I want to talk about or what I want to do with their pet. So I find a visual impact is really important for that. Then it's hard for us to understand or for the client to understand which treatment is best. So we need to be confident in what we're recommending. And that's why I always use a multimodal approach. So I'm going to cover what I would usually do for these different cases today to give you an idea. So first of all, in my objective assessment, I like to use a stance analyzer. So here we've got Shrimpy, and she's getting fed a treat. She's got 1 foot in each quadrant, and that allows us to see where she's standing and putting her weight. So this is what it looks like up close. So Shrimpy actually has bilateral arthritis in both of her elbows and in both of her hips. And from this, we can see that the left, so that is this one here, the left front elbow has much less weight. The normal stance would be 30%, 30%, 20, 20. Much less on this left front elbow, and also less on the right. So of the 4 joints, these are her 2 most affected. But this is a very visual way that we can then have our clients understand what we are seeing and feeling in our clinical examination. Okay, so now talking about those modalities, I said I'm going to go through 4 this evening. I'm going to talk about targeted pulsed electromagnetic field because I use it a lot. Therapeutic laser, we're going to go through. Ultrasound, and then no discussion about joints and osteoarthritis is possible without discussing movement medicine or exercise. So I'm going to try and take you through a simple explanation that I use to explain to the owners. I think if we can get the owners to understand what we mean, then they're more inclined to follow up with therapy for their pets. Okay, so first of all, briefly to take you through targeted pulsed electromagnetic field. So the type of energy is, it is a pulsed electromagnetic field. It's nothing to do with magnets. It's batteries that send a signal around the wire, and this induces a field. And that uses the body's own anti-inflammatory process, and it induces nitric oxide, which, as you probably recall, is an anti-inflammatory pathway and an anti-inflammatory mediator. So the effect of using this is it reduces swelling, reduces pain, reduces inflammation, and helps the recovery. The pain pathway component that it acts on is at transduction. It's very easy to use. We put it under the pet's bedding. I'll use it at the practice as well. And it's also safe to use alongside prescription medication and also all the other modalities that we're going to talk about today as well. When I'm initially using it, I'll usually use it 2 to 6 times a day, depending how acute the condition is, whether it's very acute and new, or whether it's more chronic, how much pain the animal is in. And the time to effect is a number of days. So I really like using the Assisi Loop alongside my initial consultation, where I select from therapeutic laser or therapeutic ultrasound. There's not many situations that I don't use an Assisi Loop, because it does 2 things. One is it empowers the owner at home to have the ability to make choices for their pet. And it's also very safe. So there's very few conditions when we can't use it. If this is new to you, there is a really great paper by Gaynor that's written on this slide. This provides a really nice summary of electromagnetic field therapy in veterinary medicine, all the different times that we use it. So for me in my practice, I use it in lots of different situations. So I put a few pictures here. This is Momo with intervertebral disc disease at grade 2, so painful. This is a doggy that had a nerve plexus problem, a brachial plexus issue. This is a cockatoo, funnily enough. And here we're using it because it had an injury from the ring that was on too tightly. This is Charlie. Charlie had a femoral head and neck excision, or a FHO surgery. So this is afterwards to help him recover. This cat actually had inflammatory bowel disease. So very useful to use this modality for wounds as well as pain medication. And then also this little doggy has multiple joint osteoarthritis. Okay, so I said it would be brief for each modality. So let's go to the next one. The next one that I already watched some of the information that Echo gave you tonight. And so you now already know that therapeutic laser has many different uses, not only joints and muscles and nerves, but that's what I'm going to focus on this evening. So I like to use the name therapeutic laser because there are many different terms out there that clients have heard, and I like them to understand what we're doing. Another term I like to use is photobiomodulation. So this helps to explain that it's photo or light that's having an effect on cells. So what's the mechanism of action? It's a photochemical effect, which then upregulates the cellular function. There are different ways that it works, but the one I like to remember to tell my clients is that it upregulates the energy component of the cell. The energy component is made in the mitochondria, and that energy is ATP. And the effects are, again, similar to the Assisi Loop. We're reducing swelling, reducing inflammation, reducing pain, and improving the tissue recovery and repair. So this, for me, is one of the reasons that I use these 2 modalities together very often. Therapeutic laser works on several aspects of the pain pathway. It's working at transduction, transmission, and also modulation at the spinal cord. So it has more impact. Frequency that I use in my practice is actually once a week, unless the animal is very painful. Now, this is for logistic reasons. Myself, how often I can see the patient, as well as how busy we are, and whether the owner can come to see me or I can go to see the owner in more frequently. Ideally, it's great to use 2 or 3 times a week in the initial phases. What I find is the time to effect depends on the type of tissue. So for muscles, where we always have, if we have a joint problem, we have ligaments and muscles crossing over that joint, that will become painful. We have the joint capsule that's making the synovial fluid, that becomes inflamed and painful. So we're always talking about soft tissues when we're talking about osteoarthritis or joint issues. It's always a package of things. When I'm using it for muscles, I find that they will improve with 1 to 2 treatments and start to feel much better. This is wonderful because this allows the owners to be encouraged to bring their pet back. And that means that they're more willing for us to help them in practice. When I'm using it over joints, and say we have an acute cruciate rupture and we want to try to reduce that inflammation and pain, then generally this will take 3 to 4 treatments, and again that's over several weeks in my hands. Arthritis, again the same. So I try to help the owner understand that this is not just a one-time thing. It's something that we build on to support the patient and help them to feel better over the coming weeks. And then we decide on the frequency that we need to use it. I've got a couple of pictures here. You can see a rabbit and a cat. I use therapeutic laser in any species. And I saw on the slides there that when Echo was showing you, he circled and showed you that many different species are able to be used from the machine. The best thing about the companion laser is that it's super easy to set up. You don't really have to think too much. You do have to think, but not too much to get it working. So this little video is of me showing the handpiece. I'll just let it show you.
They're moving at the right speed, so it's nice and comfortable for him. It gives a little bit of massage and warming as we go. And if we move it too fast, you'll see it goes yellow. And if we move it too slow, it will go to red. So it helps us to know that we're controlling at the right speed to get the best effect for Kaka.
That's why I really like this laser. So not only does it allow me just to put in the factors of what area I'm treating, the coat length, color, skin color, the weight of the dog, all of those things, or pet, all of those things are super easy. And then it tells me how long I need to use it. It's also great for my techs to use, or my nurses. Maybe their anatomy is not as perfect. This allows us to really focus on a larger area than just the joint, and it involves all of those muscles that I just mentioned to you that are such an important part of joint care. I only use a class 4 laser, and the companion laser allows us to move the probe, and it provides a massage and warms the tissues as we're doing it. So it feels fantastic. There is a great paper by Dr. Miller, and this explains why we want to use a higher dose, I guess you could say, to get the joules to the depth of the tissue so it's more effective. But I'm going to leave it for Emily to talk to you about the companion laser. In particular, I'm sure she'll mention Dr. Miller's paper. Okay, third, we're already up to the third one, is the therapeutic ultrasound. So a therapeutic ultrasound uses sound energy as a consistent wave. And the method of action, or the mode of action, is via heat and vibration. And these do different things. So the heat, or the thermal aspect, that improves the soft tissue extensibility. improves vasodilation, so bringing in a good blood supply, reducing pain, and reducing nerve conduction, which means that it's working on the transduction and transmission components of the pain pathway. Mechanically, or the vibration component will help to reduce edema and improve tissue permeability. What do we need to know about therapeutic ultrasound? Well, the pet needs to be clipped. We need to constantly move the probe, very similar to our therapeutic laser, but we also need gel to get that contact for that sound wave to travel. So this sometimes may be a reason that I would prefer to use my laser if the patient hasn't been clipped. But if it's a situation where we've got muscle spasm or pain or muscle contracture, such as quadriceps contracture, a tendinopathy, something to do with a tight joint capsule that I want to help stretch, then this is the time when I really want to use my therapeutic laser, because it helps to warm the tissues and allow us to do that. There are some parameters that you need to know, but the machine is very easy to set up. And I think Emily is also going to talk to you about some ultrasound machines. So it has a choice of, when you consider the duty, that depends on continuous mode will be heating, and a pulsed mode will cut that heat down. The frequency so my machine is the Chattanooga machine. So I have one probe and I can choose which frequency I run that probe head at. 1 megahertz penetrates deeper. 3 megahertz is more superficial, so it depends where I'm going to treat, and I'll show you in a couple of cases. We also have the intensity, and the different machines will have an intensity anywhere between 0.3 and 2 watts per centimeter squared, and our intensity depends on the acuity, how recent the injury is to the tissue. We always try to use the duration of the head area of the probe, so however big that probe area is, into the tissue times 2.5 minutes. So if I'm doing an area that's the size of, say, my 2 fingers, that might be 2 probe heads. So it would be 2 probe heads times 2.5 minutes. Number 4, exercise, movement medicine. So as I said before, no discussion about joints or about osteoarthritis can be had without talking about movement, because movement is medicine. It's also the only one of our modalities that works on the brain's perception of pain. So it uses the pet's own energy, which is great. We don't have to put anything in except maybe some treats. And what happens is the brain produces endogenous opioids, serotonin, endocannabinoids, and dopamine. So these feel-good factors help the pet to feel better, and that alters their perception. It's really important because we need to think about weight management. I've again put a study here for you, but there are so many different studies that have shown us if we can reduce the body weight of the patient, we can reduce the pain in joints. So it's really important that we incorporate movement and exercise as part of our plan at some point, and I'll show you how I do that. I'm going to show you this case here, this little guy, Milton. Milton is a Labrador, and he works for pieces of cucumber, which I still cannot believe. I do not work for pieces of cucumber at all. So movement involves 4 areas: endurance, strength, balance and proprioception, and flexibility. And whenever we're talking about movement, we just need to be consistent, especially if we're talking about pets that are more senior. And if we're dealing with something that's an acute injury, obviously we need to rest first. So movement may come into it later. Okay, so similar to the slide I showed you at the beginning, showing you where the different pain medications work, this is now looking at where the different pain management modalities have their effect. So as we explained there, several of them are working on transduction, transmission, and therapeutic laser is also working at modulation. And then perception is where we can affect the outcomes by using exercise. So that's really, really important that we utilize as much as we can to affect the pain pathway. Okay, so now we're going to jump over to some cases, and I'm going to run through these and then hopefully have some time when I can answer your questions. You can tell me about your own cases. If you want, you can type it into the chat. So get thinking if anything jogs your memory as we go through these. I'm going to take you through several different cases and we'll look at a few videos as well. Okay, what's my approach? My approach is what my goals are, but my goals are for the animal. They're also for the owner to see that their animal's improving so that they allow me to have longer to achieve the goals of myself and the pet. So first of all, we have to make them feel better. And that's why it's really, really important to be able to use these modalities in the clinic and also have things that we can support the owners with at home. Now, I haven't talked about it tonight, but almost every patient has some kind of thermotherapy or cryotherapy. So heat packs if they're at a more chronic phase in their condition, and cold packs if it's acute or something has just happened and they've got joint effusion and I want to reduce that inflammation. When I talk about making the pain relief last, this is where we really got to think about bringing in our movement medicine, especially if we're talking about chronic pain management. So this may not be something that we go to if we're dealing with an acute case like a medial patellar luxation post-surgery or a cruciate either post-surgery or managed medically. I also do at my practice a lot of shockwave, and this is something that I bring in later. So let's start with how I might manage a case. Okay, so I showed you this little guy before, and this is Charlie. He has multi-joint OA, and his owner said to us that he walks very slowly, sometimes drags the left back foot, and he doesn't seem to want to walk. On X-ray, we could see he had some issues at his thoracic spine, and his stifles, his knees were remodeling. I can also see as he's walking there in slow motion, he's not walking that slow, it is a slow motion video. I can see that he is dragging that left back leg, but actually he puts more body weight on the left hind leg once we stood him on the stance analyzer, and his right leg slips out to the side when he is sitting. So that tells me that his right knee is worse than his left knee. Sorry, I'll bring my mouse back over here. Okay, so this was his problem list. Charlie has left tarsi swelling, soft tissue swelling. There was decreased flexion available, and we suspected severe osteoarthritis. He had bilateral stifles with swelling, remodeling, reduced range of motion. So we also knew that this was severe osteoarthritis. He's overweight with a body condition score of 7 out of 9. So we need to help manage that so we can help him feel better. And he also had very other common signs of aging, mild hearing loss and brain aging. So these come into it because we need to think about how an animal might move if they can't see or hear, or they've got some brain aging that's affecting how they feel. So it's really important to share that with the clients if it's relevant. So here's what we came up with for Charlie's plan. We wanted to manage his pain and support his mobility. So we wanted to see him weekly to do that. We started with using the photobiomodulation, the laser, and we did that to both his knees, the left tarsi, a little bit of his back because he had some spinal pain and muscle pain, and also his toes because he had some arthritis in his digits or in his toes, which is really, really common. At home, we gave him a heat pack to use because this was something that was very chronic. And for exercise, we actually shortened the length of his walk because the owner told us that after 10 minutes is when he started to drag his toe. So we said, okay, let's stop him from getting to the point where he's dragging his toe. We also make sure that we support the animal with different things. So we use some toe grips to help him to grip the floor so that he can move into standing more easily. We used a help him up harness, which you'll see in one of the videos shortly, to help him get up off the floor, to get upstairs and to move better. We talked about weight management. And at the time he was on non-steroidals. I think he was on carprofen. And also Librela. I'm not sure if you have Librela, which is a monoclonal antibody that blocks the brain's perception of pain. He had been on that as well. And the owner wanted to hold off on medication, and actually so did I, to see how he would do with our modalities. Were they working, and was that enough to sustain him? Okay, so here's a little video of Charlie. So the settings that we put into the machine, we just put in his weight, his body weight, his body condition. So we did say that he was overweight, his skin color, coat color, the length, and then the problem. So we said arthritis, and we selected the knee to be treated. And this is part of his knee treatment here. So this is our tech, and she's using the laser to more or less paint the area over the lateral aspect. And she's going in a horizontal direction and then changes back to a vertical direction. And you can see that Charlie is having a snooze. Charlie doesn't mind. He's pretty chilled about it. It's worth noting that these photos or videos that you take when pets are having treatment, the owners love them and they make great social media posts. So if you're doing social media, get the goggles in your pictures. So his treatment was probably around 5 minutes, I guess, per stifle and the other stifle. And then we also did his knee and his back. So probably maybe up to 20 minutes for this size dog all in. Then we wanted to see how he was doing with stepping over poles, because we wanted to give him something to target and improve. So this is early on, and you can see that he can't quite lift his left back leg. We also wanted to teach him to sit, but it was too hard to get on the floor. So we did an elevated sit, and you can see here he's got a help him up harness on. So this is a non-slip floor, help him up harness, an elevated platform to sit on. And we're using treats to encourage him to stand up, and then Eva there is helping him at the back to stand. And then when Mag asks him to sit, we're also helping him to slowly sit. So he doesn't have the muscle control. He's lost that because he's been so painful in his knees. He doesn't want to sit on the floor, but by us elevating the floor a little bit for him, that really helps him. So we did treat him weekly, and this is at 10 weeks. So after about 5 weeks, the owner increased his walks because he was doing really well. And so now we've got these poles at that level here, the first level. So you can see they're higher than they were before. Charlie doesn't need to do any better, but look, he's even better than his handler at stepping over the poles. He's doing pretty amazing. So after 10 weeks, he's now not dragging his feet. He's able to walk longer. And this is the video I showed you at the start. He runs out, and now he's also able to sit on the floor and get himself back up from the floor. So this little guy did super well with regular therapeutic laser. He had an assisi loop that was used at home. And when he was able, we added in some very simple exercises, and he's done really well. He was no longer using Librela or non-steroidals, but we have them in reserve if we need to. So Charlie's a good case of multiple joints being affected and how using therapeutic laser can affect and improve things. Okay, this little guy, this is Massa. Massa has hip osteoarthritis, but also an acute stifle. So his right hind leg, the veterinarian has diagnosed him with a cranial cruciate ligament rupture. So some of the common things that we see for a CCLR are joint effusion or swelling at the stifle. So you can feel that little pocket of fluid on either side of the patella ligament. The cranial draw sign or thrust. pain on extension of the stifle, or in fact, any motion, range of motion of the stifle. They don't like flexion either when it's severe. And then also a medial buttress sometimes forming. So it depends. There might be a partial tear that's been going on for some time, and there's been some remodeling, and now things are more significant. So we do often see that. And this situation with MASA is quite similar, very different, but similar to a plan that I might use in a medial patella luxation patient, or after they've had surgery, or a cruciate patient after they've had surgery, and also in the conservative patient. So MASA, at 14 years old, his owners did not want him to undergo surgery. So let's have a look at MASA moving here. So this is him walking, and you can see the right back leg is really sore. You can see he's leaning his body weight to the left, and he's taking very short steps. On examination, we found that he had right stifle swelling or effusion. He did have a cranial draw, and I knew that had been present for 3 weeks from the veterinarian who sent him to me. We also knew he had left hip osteoarthritis because we'd had previous x-rays, so we had to think about that too. He had a mild left head tilt since he was a puppy, and so he did circle to the left, but that was not something new to worry about. And we also noticed that he had his left front leg quite wide. Sorry, I think it's his right front leg quite wide. I've written it down wrong there. Okay, so yeah, it's his right front leg. So this is MASA on the stance analyzer. So no surprise for us as veterinarians that he's only got a small percent of body weight over the right back leg with a cruciate rupture. He's only got 3% of body weight there. He's also got a lot extra body weight over the left front leg and less on the right front leg. So I'd sort of expect him to have a bit more weight shifted forward if he's only putting 3% on this back leg. So this makes me go, okay, I might have to look at this patient a little bit more, but let me help his knee. This was our plan for MASA. So we wanted to do laser, use an assisi lube that the owner could take home. We taught them to use a cold pack after exercise, but a heat pack for his muscles when he was relaxing. He had to restrict exercise on non-slip flooring, and we also recommended using toe grips because they help to give better biomechanics, so he could use his affected leg when he wanted to. Okay, the settings, very easy once again into our machine. We put in MASA's weight, his body condition, so he was lean, skin color, coat color, length of the coat, and then the problem area, we were doing the stifle on one side, the knee on the right side, and the hip on the left side. So this is our tech treating his knee, only the lateral aspect again in this video because it goes on for too long. This patient likes to stand, so we have to be able to treat him in standing. And you can also see that we're going quite high up on his quadricep muscles because these muscles are often very sore in dogs with knee issues because the quadricep muscle is turned on and contracting to help them lift up their leg. Okay, this is MASA's progress after 3 sessions. So just 3 sessions, 3 weeks. This will be 2 weeks after meeting him. And you can see he's got much, much better use of that right back leg. So not only treating the joint, but treating the muscles. We put him on the stance analyzer again, and we can still see that he's not putting as much weight as he should be on this 11% here, but he's also not putting as much as we expected on the right front leg there. So we had another look at him, and we actually found that he had a medial shoulder instability. So looseness or laxity in his shoulder, which is pretty common in his breed. And so we also did another cal treatment. After 3 weeks, we started adding in the shoulder. And again, very easy to put the information in to treat arthritis and shoulder setting. And you can see we're getting down to the tricep muscles, inside to the pectoral muscles, as well as then up towards the shoulder joint. And he looks pretty happy there with his tongue out while he's having his treatment. Okay, our next case is a femoral head and neck excision. I hope you are not all falling asleep there. I should probably tell a joke, but I don't have one ready, so you'll have to just bear with me. All right, this is Cookie. Cookie had a post-traumatic luxation of the hip. So you can see on this x-ray here that this femur, or the head of the femur, is no longer in the socket. Okay, this side is a little bit dysplastic as well, but Cookie had a traumatic incident that caused this to pop out. And then she had a femoral head and neck excision. So where we cut off the ball of the joint, and then there's no more rubbing here. This is not the Bichon Cookie. This is another dog I want to show you the video of, but I just want to also list through some of the common findings of post-op femoral head and neck excision. Generally, they have a limited hip extension. And obviously, depending on the amount of time it's been affected, marked muscle atrophy. They'll often be partial weight bearing, or like this dog, barely putting any weight on it. And we often see that the affected leg is a little bit shorter. So the greater trochanter sits slightly higher. And that means that the tarsus and the stifle tend to be more straight to accommodate that. Let's look at this little guy here modeling for us a few days post-op how much he's not willing to use that leg because the muscles are sore even though the bones are not rubbing on bone anymore. Okay, back to Cookie. So this is Cookie 1 week post-op from the femoral head and neck excision. And here what we wanted to do with Cookie is we wanted to ultrasound so that we can get more stretch in the joint or in the pseudo joint. So I'm going to show you that, not Cookie, I did badly with this, getting you the images, but I have another doggy. We also use laser for the other areas where we have pain, the other muscle areas that are painful. We added the Assisi loop, pulsed electromagnetic field to use at home. Heat pack in this case because we're not dealing with bony soreness. We just want a good blood supply. We want everything to feel more comfortable. Generally, after this procedure, we encourage exercise. So we really want the patients to be doing more walking so that they're getting more range of motion and that this false joint doesn't start to stiffen up, that we get the range of motion that we require. We also make sure that we have some non-slip flooring or toe grips so that the animal's not slipping inside the home environment. Oops, I was going to show you Cookie. I still am. There you go. So here, this exercise, I'm actually walking him diagonally across the road because it changes the dynamics. See, when he goes this way, we're looking up the incline. He uses his affected leg a bit better. That's because he can't quite, one leg is a little bit shorter. So if we ask him to turn the other way, it can sometimes affect things and how they walk. So using zigzag up a hill is a great exercise post femoral head and neck excision. Okay, let's look at this stunt doggy showing us the ultrasound that we're using. So because it's the pseudo joint, we often find that the quadricep muscle is very tight. And so too is the joint capsule that the surgeon has repaired. So here we've used an ultrasound setting with the 1 megahertz probe so it gets a little bit deeper. I know it's a small dog, but I want to get through the initial layers of tissue and deeper into the joint. So I'm going to use it 3 to 5 centimeters, continuous wave so we have a thermal effect, intensity at 0.8 because we're just after surgery. The area is clipped. We keep it moving, and what you can't quite see here is that while the they're using the ultrasound. Actually, the second person is trying to extend that little leg. You can see he's fighting it, but we're trying to extend and do a quadriceps stretch as we're using the thermal energy to warm things up. So that's one really good way to use ultrasound. Susie is also an ultrasound case. Susie is a young dog, 6-month-old, and she had several things, so we don't know the full history, but a left proximal humeral fracture that was repaired, a right scapular fracture that was repaired, but she was left with a right neuropraxia and a contracture. So in the next slide, we have her video. So she's not using that right leg at all. She can't place it yet. Now, my hope in this situation was that she would regain her nerve function from whatever had caused the problem, but this takes time. And in the time it would take her to recover, I needed to make sure she didn't lose range of motion in her joints, which by the time I met her, she already had, so we had some work to do. So we needed to use ultrasound. We also wanted to use laser and photobiomodulation in some areas. Again, a sissy loop, heat to help encourage and allow the tissues to stretch when the owner was doing things at home. And then we also had to teach the owner some range of motion and how to stretch the tendons. Let's look at her settings. So here we are doing the carpal flexor tendons. And so we've used the 3 megahertz probe. This will do more superficial, as I just want to get these superficial muscles. I'll show you on the next video. Continuous wave, because I want to get the thermal effect again. This is more chronic, so I'm going from 1 to 1.5 watts per centimeter squared on my intensity. I clip the area, and then I have to keep that probe moving. And it's also lots of gel to get the contact. So this is the very small area. It's only about 2 probe heads that I'm treating. I'm treating near her accessory carpal bone where the tendon attaches, and that's pretty much it. But I'm going to be doing this for 5 minutes. Okay, so this is the part that we're treating here. I'm trying to work on this tendon, and you can see that here is the contracture, so she can't extend this very well. And so we showed the owner some manual therapy to do. This is me after. And so you can see I can get some extension there, but it's still very much blocked. That's by both the tendon, but also the carpi itself, because that hasn't been put through its range of motion. So we had a lot of work to do with this puppy. Unfortunately, she didn't recover use of her leg. The nerve didn't return, whatever nerve injury she had that was done at the time of the car accident. But she's a very happy dog. She's about a year now, and she runs around on her 3 legs. So she's supported. She can use this paw to do some things, but not very much and not weight bear. Okay, now I've got 2 cases to finish off with. These are osteoarthritis in senior pets. So Summer is elbow osteoarthritis, and then our next doggy is hip osteoarthritis. So with Summer, she's a 12-year-old chocolate Labrador. She's overweight. This is her standing on the stance analyzer. So, well, she's not here. The stance analyzer, she's got only 19% through her left front leg. We're expecting 30%. And so we can see that most significant for her is her left front leg. Let's have a look at her walking. Waddle, 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 because she's overweight. And we can see that both those front legs are stiff. She's just a stiff doggy. We did have x-rays, and we were able to assess her elbows. We could see that she had little pressure sores starting. So very simple thing to do was to attach some little elbow sleeves to protect against that and make sure it didn't get any worse. And then this is her goniometer. So we're measuring the angle, and the elbow angle should be 25 to 30 degrees. So somewhere up here. And this was her flexion angle. So that of course means she can't really bend her elbows to go into a drop position. She had both elbows very thickened with limited range of motion, and the left elbow being much worse, which we could see on the stance analyzer. Her tricep muscles were very tight. So this is her having her treatment. So here we are trying to get as much of her elbow as we can with this particular side. And then here the tech is just abducting her elbow slightly to get underneath there so that we can treat that as well. So again, it's probably somewhere between 3 to 5 minutes to each elbow that we're treating. So we have plenty of time to slowly go around and make sure we've got it all covered, as well as utilizing the therapeutic laser to cover some of her tricep muscles and also, you know, the muscles that are crossing the joint to help her to feel a little bit better. Okay, last case. I told you I would come back to Milton. This is Milton and his sister Mason, who is this one here. Mason's had bilateral TPLO procedures to to manage her cruciate ruptures. And she's doing great now, but I still do help manage her as well, treat her. And this is Milton, who works for Cucumber. And these are his x-rays. So he has a very severe hip dysplasia that's progressed to severe osteoarthritis. Since these x-rays, one of his hips has dislocated up above the socket, but he's still doing well. We use therapeutic laser monthly to maintain his hips. They have a loop lounge that he lies on a couple times a day. And then we really focus on what we can do with his exercise. So this is Milton showing us the poles. Now, he's not going to get any higher than this, but just by asking him to step over those poles and keep things fun and keep him moving is helping with that movement medicine. Another configuration for the poles, and actually Milton is a master at exercise. He does elevated sits, he does all sorts of backwards walking, sideways walking, all of these simple things that help keep him very mobile. Okay, so I think this is my last slide. So my therapy summary was, what can I do now to make the pet feel better? Because if I make the pet feel better, the owner's going to see that, the owner's going to feel more comfortable about that. And they'll return to us for further treatment. So what I do is I try to use some things at the clinic and then send them home with the owner. I choose in the first appointment either laser or ultrasound, whatever's going to be most impactful, and then repeat the others at the subsequent appointments. Sometimes I will use TENS. Again, we didn't talk about that tonight, but TENS is a good way to manage pain as well. And then later on, I'm always trying to work out how I can manage that pain longer term. So making the pain relief last. And for me, and in the case of this is Milton, Mason, and their sister there, Morgan, they are managed by monthly, just touching base with them to do things like give a cartrophin injection, check on their exercises, feel what's happening with the joints, and make sure that we're delivering that therapeutic laser again to keep them feeling comfortable. This is just some of the references for you if you want to access those. And that's all. So now I'm open to questions, and let me see if I can load the screen. Shall I just stop? I'll stop sharing. Well, I'll leave my screen for a moment. Shall I look at these questions, Echo? Is that what you'd like me to do? Yes, I got a nod. Okay, there's lots of questions. Let's see what we've got here. Can variations in pain, neuromodulation between brachycephalic and, oh my gosh, can these affect the outcomes with laser? I am thinking, I don't see why. I'm thinking that brachycephalic dogs, obviously they have more issues with their cartilage. So we might expect different projections with how their disease will progress. But I would expect good response with my laser, but I might expect a faster tracking of the disease. Does that answer your question? Certainly, we might see these breeds are more affected with multiple joints, and that can definitely impact things. Next question, what are the quantifiable difference in intra-articular temperature or metabolic shift in tissues following low-level light therapy? Wow, who wrote this one? This is really mean. Gosh, that one is going to go straight to Emily because she can answer that. Because these are lots of detail. I want to help you as much as I can, but Emily can look at these, or I might try and reply rather than being on the speaker. I might try and have a think. Can acupuncture, please ask an acupuncturist. My gosh, you guys have gone deep. Please ask an acupuncturist your question regarding TCM. I do not do acupuncture, my colleagues do. How should point selection and stimulation techniques, manual acupuncture, acupuncture be adjusted in obese versus lean animals with OA? So for this situation, I'm only going to comment on, well, actually, again, I won't be commenting on electro or acupuncture. So I can only comment on therapeutic laser, and the settings on the machine help you to modify that. So if a dog is more obese, you'll need to use a higher amount of joules to penetrate. With respect to manual therapy, you might have to dig your thumbs in a little bit more to get through some of that fat. Another question here, in cats, how can we objectively assess the autonomic and analgesic effects of acupuncture? You guys are hilarious. Next time, get an acupuncturist to talk to you. How can we objectively differentiate between nociceptive and neuropathic pain components in canine and feline OA? And what non-invasive tools best align with this distinction? How can we differentiate? Well, nerve pain causes neuropathic pain. Nociceptive pain is the sharp pain when you I guess, cause pain at the site. So if a dog stood on a thorn, that would be nociceptive pain. Neuropathic pain could be a pinched nerve in the neck. So these are diagnosed on your clinical assessment, and then you might use non-invasive tools. Are you talking imaging? Then that would be a question for an imaging lecture. Considering feline species low pain expression threshold, what neurobehavioral markers? Oh my God, you guys are next level. I am just sorry. What would I do with a cat? For a cat assessment, I ask the owner. I take videos of what they're doing at home, and I look at how they're jumping. Are they jumping up? Are they jumping down? What are they jumping from? How are they moving inside the home? And that can help me to understand what's happening. We know in cats that they have bilateral disease most commonly. We know which joints are commonly affected, so that helps me. I'm thinking elbows, I'm thinking the lumbosacral spine and hips. So those things can help me to identify. But yes, cats are difficult because as a predator, they don't like to show their pain. So it can be difficult to assess them. As for biomarkers, I do not have any needles in my practice. I only have modalities, so I'm not utilizing anything to help you with answering that question. Somebody here says, I saw you have 2 different laser brands. I have about 5 lasers in my practice, not different brands, lots of different types. Which one do I use most often? The reason I like using the companion animal laser is because it allows for more joules to be delivered to the site. It also allows for more area to be covered. So if I have a teeny tiny dog and I'm doing a teeny tiny area, just one joint, then I can use a point-to-point laser. If the dog is bony, I might choose a point-to-point, but I prefer the companion because it has that massage ball. You've seen the heads, I think, that Eco showed you before. The heads are balls that move. So if you put pressure that into the pet's coat and into their flesh, then they get a massage at the same time and it's warming. So if I'm treating myself, I 100% get the companion laser. And if I'm treating a large animal with musculoskeletal pain, with a large joint, backs, I always use the companion laser. And also degenerative myelopathy, but that's because it's got the studies on it. There are some here that have come through in Indonesian. Would you like to translate those, or perhaps you have later?
Okay, actually, talking about now osteoarthritis management, especially for chronic osteoarthritis management, and
Yeah.
it happened in geriatric dog. In your opinion, how acupunctures can give some expressions of pro-inflammatory like TNF alpha and also interleukin 1 beta if we compare with non-steroid anti-inflammatory drug if we do in the long terms. So
Yeah,
what is the
so
synergic effect
guys,
of this?
I guess my bring to you tonight is to show you how to clinically apply the tools. And it sounds like a lot of your questions, you're wanting to have academics that have studied acupuncture to answer. So I don't treat with acupuncture. What I do know about acupuncture is that the link between acupuncture and physiotherapy is that we have a very good understanding that the mapping of the sites from a traditional Chinese medicine perspective and the sites that I might select for managing pain are often very similarly related. And it makes sense because I will focus on trigger points. And trigger points are what are commonly occurring at the neuromuscular junction where the nerve goes into the muscle. And they are actually, of course, the points for acupuncture. But with respect to looking at how these pro-inflammatory mediators are affected or how that influence with non-steroidals, I think you need to speak to an acupuncturist that's working in academia and has these at their fingertips. And that's not me. I feel like you next need to do an acupuncture lecture from the looks of this, Echo. Is there anything else I can help with respect to modalities? Here's one. I've got one here from Sheila.
Yeah, actually, and the second question's from Sri Suharti, talking about in general practitioners in veterinarian, how we make sure that the non-invasive therapy like acupuncture can be applied evidence-based, not only by subjective reasons. So it has regulations that when we want to use the non-invasive therapy, is there any complementary interventions in the animal?
So there are some contraindications.
Yeah. When we do acupunctures in evidence-based, actually.
Yeah, your evidence. And there's a whole book on it talking about therapeutic laser. But there are so many publications about therapeutic laser, about pulsed electromagnetic field, about exercise, about TENS. There is a lot of literature out there. So you can look further and explore into that to help you understand how the modalities work. We actually have a lot of knowledge. But I also like to look at how the patient progresses and how they respond. So for me, I no longer use medication in my practice. I only offer modalities with manual therapies. We didn't talk about that tonight, but what my hands can do, and with these different modalities that have their evidence behind them. So there is a lot out there. Use the search engines to help guide you. And I guess that's another good question for Emily with respect to papers that Companion have about all these different areas. They have a very good website, and on the website you can go in and look at all the different aspects and download your own information and do your own review. So I've been using therapeutic laser now for 10 years. And when I first selected my Companion machine, I was in the US. I went to about 10 lectures of laser therapy and then spent a lot more time talking to as many people as I could to get an understanding. So it is really important to be happy with what you're using, I guess, is my point. And you should always be able to ask the company to send you scientific papers, and they should have them at their fingertip.
Okay. Thank you so much, Jane, for your presentations. But unfortunately, the time is limited. I'm sure that there are many questions that our veterinarian in Indonesia wants to know more about your
I'm
presentations.
sure there
But
are. Thank you. I'll try and write a few
unfortunately,
replies to the questions
yeah.
on the chat while I finish up here. Thank you.
Okay. Thank you very much for your presentations. We hope that you can come to Indonesia in offline seminar. So thank you very much for your presentations, and it's very insightful for us as a veterinarian in Indonesia to learn more about how the modality and of course how the medical rehabilitations can be done as we are veterinarian in Indonesia. Okay, thank you very much, Jen, for your time. Well, thank you very much. Okay, thank you very much. So we will move to the second speaker. I will try to introduce you first. So we have the first presentations from Dr. James, and then we move to the second presentations. So the second presentations, we have also spectacular speaker, Emily Ashdown. You know that Emily Ashdown, I can tell you a little bit more about Emily Ashdown. So Emily Ashdown graduated from Hellsvin in 2013 with a diploma in veterinary nursing and registered as veterinary nurse with Royal College of Veterinary Surgeons. Since 2021, Emily lists on the Register of Animal Musculoskeletal Practitioners and is a member in the Institute Registered Veterinary and Animal Physiotherapist. So, welcomes Emily Ashdown. I hope that you can stay on the web. Of course, the next sessions, we will move to the second presentations. Pay more attention to this second presentations. And for Emily, times and screens is yours.
Perfect. Thank you very much. I'm hoping you can hear me okay, because I was having some technical glitches not long ago, so hopefully all is going to work. And thank you, Jane. It's kind of intimidating following someone with so much knowledge and information. I will definitely be taking kind of movement medicine forward, because I like that phrase. So I'm also a little bit intimidated by those questions, so hopefully I can answer as much as I possibly can. So going into the second stage, so Jane's concentrated a lot on the clinical benefits of our devices, and that's incredibly important. We don't do the job we do just to hope that it's going to work. There's a lot of research, a lot of time, a lot of education goes into the technology to make sure that we're going to give our patients the best clinical outcomes that we possibly can. So I didn't want to cross over in terms of going through the clinical side. I wanted to kind of look at the other side, the technology, and how much do we actually understand in terms of our device, whether we have the right components to be effective. So rather than looking at the clinical outcomes, let's look at the actual device and break down laser therapy so that you have a better understanding of what you're actually looking for within your device. I had the pleasure recently of lecturing alongside Dr. Alves, who is an incredible vet that has been publishing so many clinical application papers on laser therapy. And we were talking about how, we talk about a couple of elements, classification of laser, maybe the wavelengths, but we don't talk about the protocol as a whole to, again, make sure that we're getting the best for our patients. So that's what I want to focus on kind of in this stage. So I've already been introduced and kind of my background is veterinary nurse, veterinary physiotherapist, hydrotherapist, and I've been in the industry for about 12 years. So hopefully I can, again, give you some of the knowledge I've picked up as I've gone along. So starting with the basics then. So what is the difference between white light, LEDs and laser therapy, laser light? And it comes down to a couple of things: how many wavelengths we have and how coherent and consistent those beams are. So white light, so our lights in our rooms right now, if you turn those on, we have lots of different wavelengths and they are non-coherent. So they are bouncing all around the room so that we can see in all the different corners. So we don't have a therapeutic effect because we don't have the consistency and the condensed amount of light to really target through the relevant tissues. We then have our LEDs, which is the blue waves over on the far right. Now these guys are monochromatic, so they are the same wavelength, but they're non-coherent. So again, when we turn that light bulb on, or the LED light in this case, those wavelengths are more readily scattered because the wavelengths are not nicely compact together. So when I'm aiming my beam in a certain direction, it's getting that more scattered approach there. So again, I'm not getting the consistent condensed amount of light in the direction I'm aiming. Then we have our laser light. So again, we're monochromatic, so we're the same wavelength. So we're going to have, we can have a therapeutic effect on tissue, and our beams are coherent. So this time, as I direct my light in one direction, I know majority of that light is going to go kind of in the same direction. We'll still get a little bit of scatter, but rather than kind of LEDs where we get a lot more scatter across a large surface, this is going to be more coherent. And again, I'm going to get more of my light saturating those tissues that I'm trying to target. So laser devices for many, many years have been quite complicated things to understand. And the reason why they're so complicated is because they have so many different elements. Now, we touched on research just a moment ago, and I did a review recently in looking at how much laser therapy research is published on PubMed, which is one of the publication platforms. On there, if I search therapeutic laser therapy, there are over 103,000 papers on that subject alone. If I search photobiomodulation, there is over 8,500 papers. That is a lot of research on just devices. And to give you a comparison, ivermectin, which is obviously a common drug, there was 10,000 papers. Pulse mag, there was, I think it was 2,000 papers, and not to discredit, because, you know, 2,000 papers is still a lot of research, but that just goes to show how much has gone into laser therapy and photobiomodulation over the last decade or two, because that is not a small amount of research. Now, not every single paper is going to be accurate. Not every single paper is going to be for the benefits, and the reason being is because there are so many different components that make a laser effective, we've had to learn what those components are. So in the last 5 years especially, we've seen a real drive in more clinical applications and being much more consistent with the results in those papers. And that's because we've learned so much in the last 10-20 years about what components we need to have in our device to be effective. We're starting to get the idea now. It's a bit like a recipe in a cake. You know, we need to have the right ingredients to make the cake taste nice and turn out okay. If we have the wrong amount of just one small thing, it can change the whole taste and structure of the cake. So that's exactly what we've had to learn. Now, to help try and make this make more sense, myself and a colleague recently, we were like, right, we need a way to help people remember all these different components. And we came up with this acronym of see wider. So instead of being laser focused, you're going to see wider at the bigger picture. And what those all stand for is C is for class of device and the power, wavelength, irradiation or irradiance, D for deep tissue, which is your dose and your delivery, E is for emission, and R is for research. And as I said, what kind of happens in most cases is people will look at class of device and maybe the wavelength, but then they stop there. They don't take it one step further and look at a bit more in the device to really see what else they need to be effective. They don't look at the whole protocol. And like I say, when I had the conversation with Dr. Alvers, and we looked at, every time he's published a paper, and the reason that, he can be effective is because he has the whole protocol. He has considered all of these elements, not just how powerful is my device and what wavelength I'm going to use. So we're going to break down these a little bit more, so hopefully they make a bit more sense. And especially we're going to look at irradiation, dose delivery, emission, and obviously just highlight some of the research as we already have. So C is for class. Again, this one's probably one that you're all very familiar with, and it's the buzzword of do we have a class 3B or do we have a class 4 laser? Now, class relates to three things, but two things that we talk about most. How much power we have, the health and safety implications of that, and the spot size. Because if you can imagine you have more power going through a smaller spot size, that is a different intensity to high power going through a bigger spot size. But we do tend to focus mostly on how much power we have and what the health and safety implications are. Class does not influence how deep the light can go, and it does not on its own affect the efficacy of the treatment, and you'll see why as we talk through. Power is still important, and we'll talk about where else it's important, but class on its own is just telling us how powerful the device is and how safe it is to use. Now, class 3B and class 4 are the most common therapeutic lasers that we talk about. So a class 3B laser is up to 0.5 watt of power, and a class 4 laser is anything over 0.5 watt. Now, this is another reason why I don't like to focus purely on class, is because a class 4 laser could be a 1 watt laser, a 5 watt laser, a 10 watt laser, a 25 watt laser. They are all technically class 4s, but the power difference between all of those is incredibly different, and the abilities in all of those powers is incredibly different. So whilst, yes, we want to be in that class 4 range for certain, treatments when we're looking at, again, particularly deep tissue, chronic, larger patients, we don't just want to tick the class 4 box. We want to understand all the other elements as well. So again, this is going to make a bit more sense as we go along. Second, so W is for wavelength. So this is how far or how deep our light can travel. If we do not have the right wavelength, it doesn't matter how much power we have at the surface, we will never be able to reach our target tissue. Now, we operate within what's called the therapeutic window, which is anywhere between 600 and 1100 nanometers. So if we use a wavelength within this spectrum, we are going to have a therapeutic effect on tissue. The challenge is that within that window, some of those wavelengths are more likely to be absorbed by what we call incidental absorbers. So melanin, hemoglobin, oxyhemoglobin, water, fat, they all want to absorb our light. And the more they absorb our light, the less we will have at that target tissue. So we want to pick wavelengths on this spectrum that are least likely to be absorbed by these incidental absorbers. And the two most common wavelengths that have the most research behind them is 810 and 980. Now, we still choose multiple wavelengths because not one wavelength can do everything. So 810 is a great overall photobiomodulation wavelength. However, it can be absorbed more readily in darker melanin. So if we have the black Labrador, and we had the 810 wavelength, their melanin is likely to absorb a little bit more of that light than if we use the 980 wavelength, where actually it can penetrate through melanin more easily, but then it does get more absorbed a little bit more by water. So there's no perfect wavelength out there, but we choose the right combination so that when you enter in your patient characteristics, it's going to alter the wavelength based on those characteristics, so we can get the most light deep into our tissues as possible. The one thing that is out there that can cause a little bit of confusion is there are some claims about using photobiomodulation and targeting hemoglobin. Now, to this day, there is no research that backs the targeting of hemoglobin. It is a non-biologically active chromophore, so it will not induce photobiomodulation. So at this point, there is no evidence to suggest that targeting hemoglobin will have a beneficial effect for our patients. And interestingly, the wavelength that is often promoted for this is the 915, which, if you can see by this chart, is the middle. You can see the 3 purple highlighted wavelengths there. It's the middle one. If I was trying to target hemoglobin, I don't think I would be picking this wavelength that's down this end. I would potentially be wanting to go further the other end, where we can start to see that increase in hemoglobin absorption. But again, at this point, there is no evidence to suggest that this is something we want to do. This next one's my favorite because it's not talked about enough. It's a newer area, I say. In the last few years, there was a study published by Harvard that I'll talk about in a moment, where this really came to light. Now, one of the old myths used to be, oh, well, light will only penetrate so many centimeters, so it doesn't matter how much power you use, it won't get that far anyway. Well, this is where actually power comes in, and actually where we can show you can get light to penetrate deeper. Light doesn't stop traveling. Its brightness, as you know, as we move further away from something, that brightness dissipates out. So the deeper the structure, the energy, the light doesn't just stop, it's just the irradiance becomes less. So the further you are away from the light source, the lower that irradiance source. So irradiance is watts per unit area, and it's essentially how bright the light is when it passes through a given area. Now, the best way I can describe this to you is the effects that summer versus winter has. So in the summer, in the UK anyway, obviously everybody's summer and winter is different, but here we are much closer to the light source. So we get very hot summers, you know, sunny days, and we see that everybody is happier, more tanned, pain-free. The effects on us is much bigger. When it gets to winter, we're much further away from the light source, so the irradiance level is much lower. We have shorter days, it's darker, it's miserable. We become quite miserable, painful, and pale. So it's, you know, that just shows in itself the effect that the irradiance of light can have on us. Now, imagine going on a cellular level, and again, if we're trying to target a certain depth of tissue, if by the time we get to our target that the irradiance is really quite low, the effect it's going to have on those cells is quite low as well. If we can maintain high irradiance when we get to our deep tissue, the effect is going to be much better for our tissue. So this is something, like I say, not many people talk about. We talk about how powerful our device is, and this is the link for where the importance of power comes in, because the higher the power we have at the surface, the higher the irradiance you will have at depth. So the historic arguments, and we'll talk about in a moment, about 3B versus 4, I can deliver the same dose, it just takes longer. Well, actually, this is another element that we need to consider, because yes, it could take longer, but you won't achieve the same irradiance if you're using half a watt versus 1 watt And even if, using 5 watts, 10 watts, 25 watts, the higher we go up, the higher the irradiance at depth. And again, kind of when we look at then how we treat superficial versus deep, yes, superficial conditions will often say we don't necessarily need high power, high dose because we can access it so easily. It's when we start treating our deeper tissue structures, that's where irradiance and power really come in, because the more we have at the surface, the more we have at depth. And this, for just kind of interest here, is a graph plotted of just 1 watt penetrating through the epidermis, dermis, subcut fat, and coming into the muscle here. And this is how laser light works. Wherever our target tissue is, we have to saturate all of the tissue before we can reach that depth, that target tissue. So again, the more energy we have at the surface, the higher the dose, the higher the irradiance, the more likely we're going to get light, higher radiance, etc. at depth. And actually, we don't need, masses of light to get to the target. We just need enough that stimulates those tissues and those cells. So it all depends on what exactly we're treating. But again, if we're looking at those deeper tissue conditions, that spinal cord, just like in the DM study, that's where power irradiance absolutely comes in. And another visual for you here, just so you can see that irradiance in real time. So this is somebody's hand, a laser beam being shown through, and then a thermal camera. And we can see here at the bottom with 1 watt, we can barely see that light reaching through. So it's not saturating all of those tissues. And this is just a hand. You imagine you're trying to treat a Great Dane hip or a spine, or a Labrador spine. It's a bit thicker than just a hand here. When we go up to 5 watts, we can see more of that light coming through, so the irradiance is higher. And again, when we get to 10 watts, again, even more of that light penetrating through, and a much clearer picture there, more irradiance as well. So how this again comes back to the age-old argument of you can treat with a 3B versus a 4. It's going to take longer to deliver the same dose. And that was the old argument. And that's called the Roscoe-Bunsen law of reciprocity. When the University of Harvard brought out their review on light parameters and identified the importance of irradiance, this theory was then debunked, because it doesn't matter how long you stand there with low power. Yes, you can reach the same dose, but you cannot reach the same level of irradiance. An example here is if I was in a dark swimming pool and I dropped a pair of keys to the bottom of the pool. If I had a cheap, low-powered torch shining in the bottom, it wouldn't matter how long I stood there, I would never be able to see the bottom. That brightness will never get brighter. However, if I had a military-grade, high-powered torch and I shined it into the pool, I will be able to see those keys instantly. So Roscoe-Bunsen law of reciprocity debunked. It's not a case of, yes, we can treat the same, it just takes longer. It now depends on what target tissue you're trying to treat. Yes, if we want to treat superficial, we probably don't need high power. So if you're treating dermal, issues, skin, wounds, etc., probably be fine. However, when we start looking at those deep musculoskeletal structures, that's where the importance of power, dose, irradiance all comes in. So D is for deep tissue. And the first part of that is our dose. This again is another really important area, and something we've been seeing change in the research quite a bit actually over the last, again, 5 to 10 years. being really aware of how to calculate your doses is important, and being aware of what the dose rates are within your devices. I speak to a lot of people that use devices and they don't actually know what the dose rates are that are built in. They just know that when they press these buttons, it gives them a total of 70 joules. Well, okay, if 70 joules is covering a very small area in a very mild case, fine. But if you're asking 70 joules to treat a large patient in a MSK deep tissue joint, not okay. So becoming really familiar on the process of how to calculate to make sure that you are dosing correctly, and having awareness of what dose rates used within the device are. We've seen a change in these recommendations, like I say, over the last few years based on research. Superficial conditions has very much stayed very similar. So 4 to 6 joules per centimetre square is pretty standard still. And again, that's because we don't need, the skin surface is really easy to treat. We don't need high doses here. Our deep tissue and unique conditions, such as degenerative myelopathy, this is where we've seen the dose rates change. There have been 3, if not 4 publications to my knowledge, all on canine hip dysplasia, elbow OA, the degenerative myelopathy case. Maybe it was just 3, but all 3 of those papers that showed positive effects in using high power, high dose, high irradiance, all used a much higher dose rate in their dose protocol. So historically, we used to say for deep tissue, 8 to 10 joules per centimetre square was fine. In our recent research in these papers, we've been using 8 to 20, and in some cases, such as DM, 20 to 30 joules per centimetre square. And that is where we've seen a big jump in response, in effect, because we really are saturating as much of that tissue as possible. So making sure that you're dosing your patients correctly, and you'll be surprised, those cases that maybe when you're using lower dose weren't responding that well, try increasing your dose rate up and see what response you now get. The degenerative myelopathy study, that study directly compared protocols where they used a low dose 3B lower radiance device versus high dose, high radiance, high power device. The 3B low dose group, they had no clinical impact whatsoever. There was no changes. Whereas the higher dose group had an average lifespan of 38 months. That's a huge change for those cases. So making sure we're dosing correctly is really, really quite important. And then alongside dose, when we're also looking at deep tissue, is also looking at the mechanism in which we deliver that. So we've talked, and you've been shown a little bit on the companion contact treatment head. And this is patented technology to companion, and it's designed to help, again, improve clinical outcome and clinical benefits. And there's several reasons why. So obviously the contact and the shape of the convex treatment ball allows for compression. So again, when we're trying to treat that deep tissue, we're compressing those tissues. So we're removing superficial absorbers such as hemoglobin, water, out of the way. So we're going to lose less light because of that. The other thing is because we're in contact, we're not going to have the same amount of reflection because we haven't got that airspace between. The construction of the massage ball allows for better collimation, tighter beam. So it's solid silicone. It has the same refractive index as tissue. So instead of a natural reflection when it hits the skin surface, it actually allows for that light to penetrate through more readily, and it minimizes those energy losses. And then just as Jane and myself, from a soft tissue manipulation point of view, having the ability to use it to help massage and work some of those tissues that either we would do manually with our hands and can be quite strenuous, or actually having the effect of heat, photobiomodulation, and soft tissue massage at the same time, again, can have some real good benefits there. And just to kind of back up the use of contact treatment head, light can reach the spinal cord. We have this study that we did that looked at, so we had canine cadaver and we placed a photo detector underneath the spinal cord, and we used off contact and the contact treatment head and measured A, can light reach the spinal cord, and B, how much light. And first of all, absolutely, light could reach that spinal cord. So the old myth of, oh, well, it's only going to go a couple of centimeters, millimeters, so it doesn't matter, absolutely debunked. Again, we can show that we can reach the spinal cord here. Secondly, when we used our contact head versus the off contact, we got up to 67% more light reach that target. So 67% more light reached that photo detector when we used the companion treatment head, contact treatment head, versus when we used off contact. So again, all of those benefits of having the patented massage ball, as we've discussed, this research backs that use there. Next, we go into emission. So emission is how that light is then emitting. So we can have continuous wave or pulsed. There is a technical super pulsed out there, but it is more of a marketing concept. However, we'll keep it simple in terms of continuous or pulsing in some way, shape or form. Now, we know if we turn the light on in continuous wave, we're going to deliver that dose fairly quickly, but we will get heat output as a byproduct. If we pulse light, we can negate some of that heat, but the problem is that will also take longer to deliver that light. So one of the issues that has been around pulsing devices is that instead of taking longer, many devices have opted to reduce the dose. So that their device seems like they are, faster and safer, when actually what they're doing is reducing the total dose that that patient's going to receive. So in terms of research and where companion sits at this moment, and again, the University of Harvard in their review of light parameters, they looked at continuous versus pulsing and concluded that there is currently no evidence to back that pulsing is more effective or as effective than continuous wave. So at this point, there is no benefit to pulsing other than to reduce thermal output, but again, treatment time often then increases as a result. One of the biggest advantages to the companion range is their ability to deliver high dose, but because of their dual fan system within the back of the unit, it manages to keep the unit incredibly cool. So people often ask me, well, why don't you design the lasers smaller? Yeah, we could. But if we did that, the heat output at a continuous wave at 25 watts would be too much for the machine. So we would rather design a system from a longevity point of view that is going to give you the ability to keep that system running all day long at high power on continuous wave without burning out the device or obviously causing risk to the patient. Then we would risk either the dose or risk the device overheating. So we haven't designed it the size it is for no reason. There are reasons, and we don't pick pulsing over continuous anymore because ultimately there is no research to say that there is any benefits. If anything, we have been removing pulsing from our protocols. The only time that pulsing can be beneficial is if there is a superficial heat issue such as a burn. At that point, pulsing can be beneficial, but the treatment time is likely to be low anyway. But from a musculoskeletal point of view, there has not been any research to prove that there is any benefit there. And then R for research. Now I split this into two categories: research, clinical research, and research that backs the machine up. If ever you are looking at a device, you should be able to see both. And when I say clinical research, it shouldn't be human research, it should be animal research. So going back to my conversation with Dr. Alves at the beginning, I said that, you know, within his studies, it is a protocol, and it is a protocol of what the dose rate is, the wavelength, the emission, how they emitted that light, what treatment, you know, whether they're in contact or off contact, the dose, all of that makes the protocol. So unless you can replicate that same protocol in another device, actually the research is device specific, not as a general kind of, okay, if you use any laser, you can achieve this. Take the DM study again, 2 different lasers we used there, 2 very different protocols. They did not achieve clinically the same things. So the device you are looking at must be able to show you veterinary clinical research to back that you can use that device to achieve good results for X, Y, and Z that they're claiming. And again, in terms of kind of research, we have all sorts of different research on the companion units, from musculoskeletal applications to idiopathic diarrhea, dental, wounds. You know, there are a whole range of conditions with more research coming all the time to back the use of our device for different clinical applications. We then also must look at, oh, sorry, I've gone too far. Research that backs the device, and I'll kind of show you that in a moment, actually, rather than talk about that too much just yet. For those that were kind of interested, so this was the paper, the review of light parameters, and this, again, when you're looking at a different device, this is the paper I would refer to first. This is independent, so this is not, you know, this is not sponsored by Companion or any other company. And the universities of Harvard and Genoa, they wanted to look at why there was inconsistencies. Why do some papers say that this, some papers say this doesn't get results? And from that paper, from this review, 3 of the main things that they came out with was light reflection from the surface of the skin can be minimized by the probe being held in contact. Scattering of light within the tissue is wavelength dependent. And absorption of the light by chromophores that are not biologically active, i.e. we don't want to target hemoglobin. I think I've missed a slide in here, but it also then showed the importance of irradiance at depth of tissue and also dose. So I would really recommend you check out this paper. I'll just kind of go back for those of you that wanted to just take a quick screenshot. This paper is a really, really interesting read. And again, it's not linked to any one manufacturer or any one laser. So this would be the starting point that I would say if you're wanting to understand what you need to look for in a device to ensure that you get consistent results. And then I would then start approaching the company, and they should be able to provide you with evidence that backs up their devices, both clinically and all of the components built within their device. So just coming back to see wider, hopefully you can see now how they all link. So yes, class of device. If we're looking at deep tissue applications especially, you know, that links to irradiance. The higher, if we got a class 4, the higher the power, the higher the level of irradiance we're going to have. The wavelength, that's going to carry our light there. So again, if we didn't have enough power, we wouldn't have enough light necessarily to carry to the target tissue, depending on where that depth is. Our deep tissue applicators, again, helping to deliver more that light across the wavelength so that we get less reflection, less absorption in those incidental absorbers. You know, these all kind of interlink with each other. So when you're thinking about laser, I don't want you to just think, oh yeah, class 4, that means it must be a good laser. I want you to question all of these different elements to make sure that you understand fully how you're going to get the best clinical outcomes. And I'm quite a visual person, so I always have to have something to link to. And this is my way of thinking about it, in that I think lasers are a bit like a train. So with our class and power, that depends on what kind of train you have. You know, we can have the old coal trains, which can do a job, but they're not as efficient and kind of as effective as the newer bullet trains. Our wavelength, that's going to be our train track. There are shorter train tracks and there are longer train tracks. And depending on where you want to go is going to depend on which train track you're going to get on. Our irradiance is our train going through a tunnel. Now we can have a low powered headlight at the front of our train, and you're going to be able to see a little bit of that tunnel. But if we have a high powered headlight at the front of our train, we're going to be able to light up the entire tunnel and see everything that's happening. Our dose is the amount of people that we start off when the train leaves the first station. Now, naturally, as the train makes stops, we're going to lose a little bit, you know, some of those people are going to get off, and that's okay. We're going to lose a bit of light as we go. However, we need to make sure we have enough people left at our target, so when we get to that last train station, to make sure the journey was actually worth it. Emission is how many red lights we're gonna hit. So if we're on continuous wave, we're on green all the way and it's go, go, go. If we're pulsing, depending on the frequency of pulsing, depends on how many red lights we're going to hit, because it's going to keep stopping us. And then research is kind of Google, whatever you use, to do your research before you get on that train, to make sure it's going to take you to the right place, it's going to be on time, and that you're going to have a safe and good journey. So remember, all of those elements all mean that we're going to have a successful treatment at the end. Now, just in relation to the companion devices, as I kind of mentioned, having research that backs the device is important. And, you know, our contact treatment heads, shown by our cadaver study showing that we can get light deep, but also the review of light parameters and how we followed their research, their science, and implemented it into our devices to make sure that, yes, we can achieve higher radiance, high dosing, continuous wave, the right wavelengths. All of these things matter, because that's what Harvard have seen, that if we want consistent results, that's how we go out and get them. And in terms of our protocols, I appreciate you've already seen the IQ kind of briefly at the beginning here. I just want to draw as to, you know, how we've then linked it. So the protocols, we've got canine, feline, equine, exotic. And on the exotic, you've got small mammal, reptile, and avian. Now, patient characteristics are incredibly important for all of those parameters so that we can get the right treatment for the right patient. So our body type, coat length, and weight, these are all going to dictate the dose and how we're going to deliver it, because, you know, the bigger the patient, the bigger the body type, the longer the coat, we need a higher dose. Our coat color and skin color, this is going to impact the power that we're going to use, and the wavelengths. So like I mentioned earlier, 810, 980, depending on what color you're going to put in here, it's going to flip between them to decide which one's the safest. In terms of power, if you're putting in that they have dark coat and skin color, the system knows that we need to be careful on the amount of power that's used to make sure that, again, we're delivering the most safe treatment possible. So all of these considerations have not just been put in there for the sake of it. They've been put in there to make sure that the treatment is as effective but safe, and, you know, the research is backing what we're doing. And then when we have things like our deep tissue protocols, so arthritis, pain, trauma, edema, swelling, we're using that higher dose rate of 10 to 20 and even 30 joules per centimetre square in our duo, so that, again, we're following the research there. Making sure that we're treating appropriately and covering larger area, people often say to me, but what if I just want to treat a couple of spots? But I always say, how do you know that the tissue impacted is only here and here? Because in my mind, if I have an arthritic hip or lumbosacral disease, something like that, it's never just one spot that's being affected. We need to be treating all of those tendons, ligaments, muscles, joints, all involved 360 degrees to be effective in our treatments, in my mind. As Jay mentioned, we do have the ability to do point to point. So if you had a mild tissue fasciculation, for example, yes, we can absolutely do that. But personally, if I have the opportunity to treat the entire area and get the better outcome, that's what I'm going to do. So key takeaways from this, dose patient specific, not a general guide. You know, we want to dose specific to that patient, their weight, their body type. So they underweight, overweight, average. Clinical research should be there to back up both the device and the clinical applications for the specific device you're using. Companion has jumpstart marketing and tools to help you you know, really implement technology. The laser should meet the clinic's needs and not just be a wagon that you're just looking to tick the box for the laser. And as part of Companion, we're very lucky to have our range of lasers, but we meet all of the requirements set out by research like the University of Harvard in terms of ensuring we have continuous wave, we have the intelligent handpiece, the larger head to maintain higher radiance, and again, allowing that irradiance there. So I hope that all made sense. And I'm gonna have a look at the questions that come through.
Okay. Before we move to the Q&A sessions, let Emily take a deep breath first because many questions I have tried to summarize. So, but before we continue to the next Q&A sessions, we will try.
Laser therapy is quickly becoming a standard of care for treating acute and chronic conditions in veterinary clinics around the world.
Do you want me to go ahead and have a
Therapy
look
is
through?
a fast, non-invasive solution that is playing a major role in returning pets to their normal lifestyles faster.
I think the screen's
Here we provide an umbrella approach to tailor it
freezing a little bit.
specifically for the patient's needs. Our
So
full
can we
rehab
combine
package
laser
includes
therapy or
any
TENS
modality
while the
you
dog
may
or
need.
cat sit on the PEMF bed? Jane, I can see you've popped in there. Yeah, absolutely. There's not much research that I'm aware of that talks about contraindications of treating with multiple modalities at the same time. I always think, well, I can save time by doing multiple things at the same time. So yeah, agree with you guys there. Apologies, my zoomy thing, my scroller keeps going up and down a little bit crazy.
Okay.
So hopefully I'm looking. I don't know if you want to shout out the questions, Echo, because it's
Yes, well, I will try to share the question first, one by one. I will try to, wait a minute, I will try to share my screen first. Yes,
Okay.
can you see my slide? Okay,
There we go, yeah.
Yeah, the first question from Sri Suharti. Well, I will try to translate. Talking about the veterinary therapeutic laser practice, there are variations parameters such as wavelength and then output power, and then how the parameters can give clinical effectiveness when we do on deep tissue injury and superficial musculoskeletal injuries. How we can monitor the clinical effectiveness of these conditions between superficial musculoskeletal and deep tissue injuries. How we can monitor the clinical effectiveness. This is the first
So is
question.
this kind of general kind of how to monitor whether we're treating superficially or deep tissue? Is that right?
Okay.
I'll go with that. So it can be challenging, and I say every practitioner finds a couple of things that they like to use. I like a mix of subjective and objective measures. So subjectively, owner feedback, owner pain forms that I would send out to the owner before they come back in for a review. So I kind of know where they're at before they're coming in. And then using objective measures such as stance analysis, that's probably one of my favorites because you can be hands off and you're more likely to get a better result there than if I do, for example, muscle measurements. There's always that element of, am I measuring it in the same place? As Jane kind of showed earlier, using goniometry, particularly if you're looking at joint range of motion, joint function. Using pain scales such as the Glasgow composite, the load scoring system. There's lots of different ways out there. It's about finding, like I say, a couple of methods that you like. And I would have, so if I'm treating musculoskeletal, my methods for them is going to be a little bit different than if I was treating, for example, an idiopathic diarrhea case. I'd be probably looking at fecal scoring systems and things there. So yeah, just depends on the type of case, but that's what I would advise.
Okay, I think that is incredible answer. The second one is talking about using the generations 3. You see that based on your explanations, when we try to use laser class 3 and class 4, is there any significant difference when we see the tissue response when we use class 3 and class 4 lasers? And how we can objectively verify the result based on maybe behavior or maybe based pain scoring scales, for example, how we can differentiate between the class 3 and also the class 4 lasers, talking about the significant difference tissue response.
Okay, so if I got this right, so in terms of class 3, class 4, absolutely there's often a difference there. It's very rare that if we're looking at superficial cases, that's one thing, because sometimes using low power can be fine for that. If we're looking at musculoskeletal deep tissue chronic cases, that's where our dose and irradiance become really, really important. And typically, yes, you could deliver the same dose with a 3B, but you won't achieve the same level of irradiance. So that's where the issue becomes using 3B, not 4. So personally, that's where, you know, the higher the power, the better that we're going to have a better response when it comes to deep tissue treatments. And in terms of monitoring that difference, laser is a very quick treatment. You can have pain relieving effects very quickly. I recently did my own dog, and I lasered him. No, I stanced him, lasered him, and then put him back on the stance within minutes, and already you could see his weight bearing had improved. So if you're not sure if you know, the laser that you're using at the moment, is it effective, try doing some form of objective measurement. It has to be objective, it can't be subjective if you're trying to establish if it's working or not in these cases. So like the stance analyzer is perfect because you can see, okay, have I made a difference within a few minutes? And you should be seeing a difference with your laser.
Okay, thank you very much for your answer. And then we will try to move to the next questions from Dr. Sukma. Dr. Sukma, well, in the application of laser therapy to domestic animal, does personalized or individual protocols create inconsistent therapeutic variations? This is the first question. And then the second one, and how we do balance between clinical adaptations and the need for standardizations.
So with the first question, is it just saying that using protocols is not as personalized, is not as effective? Is that my understanding?
Okay.
Yes. Yeah, so
okay, got it.
If I'm right in that understanding, there is, yes, you might use a standardized protocol. So for example, built into the systems, we have protocols built in. However, you should be asked enough questions about the patient that make it personalized for that individual. So as we showed you on the screen there, you know, their weight, their body type, their coat length, their coat color, skin color, all of that is giving a personalized view of how to decide the treatment protocol that patient should have. So if I was using a laser that didn't ask me all of those questions, then I would say that I'm not going to be treating effectively, because that's not going to be a personalized protocol. If you are treating where you are asked those questions, that's where we're becoming more personalized. I hope that made sense.
Okay, okay. Thank you very much for your answer. And then maybe we next move to the next questions. Maybe this is the last questions from Farahia Putri. Yeah, the question is talking about, do different pain pathophysiologies, such as neuropathic versus inflammatory pain in osteoarthritic dogs and cats, require distinct laser parameters, for example, like frequency, pulse mode? And the question is, what evidence supports individualized laser prescriptions in such as context?
Okay, I think I can answer this one, but it's quite a technical one. I'm going to say yes, they require different parameters, and that is based off the degenerative myelopathy study. So in that study, we saw low dose, low power versus high dose, high power and high radiance, obviously. And there was a definite difference between the patients, and we've been seeing kind of generally, so for deep tissue general OA pain, we've been recommending 10 to 20 joules per centimeter square. For neuropathic pain, we've been seeing the 10 to 20, but even 20 to 30 joules per centimeter square being recommended. So I think we need a much higher dose for our neuropathic pain, and often because we are trying to again affect deeper structures, we need to be sure, are there any other ways that we can make sure that we're definitely getting that light to that spinal cord, i.e. making sure we're using the right wavelengths, are we using contact treatment versus off contact, because again, that study looking at spinal cord, we saw how much more light was able to penetrate there. So yes, in terms of frequency and pulsing, again, there's no evidence out there at the moment that backs that frequency and pulse mode can effectively treat spinal cord. I would almost say that actually I absolutely wouldn't use pulsing, because again, when it comes down to irradiance and dose and saturating that spine, you're going to find that very tricky to do with pulsing.
Okay, thank you very much for your answer, Emily. So actually we have many questions, but because of the limiting times, I think we have to finish our sessions. Thank you very much for your presentations, for your explanation. Of course, it will give us many insight how to do a laser in our daily activity as a rehabilitation medic practitioner. So thank you very much, Emily, for your presentations and your answer. For the questions that we cannot be answered tonight, we will try to give you maybe email to answer these questions. Once again, we give applause to Emily. That was really great presentations, and of course, answer of the questions, and that's why we choose Emily to join this webinar, because we can see that there are many clinical practitioner as a rehabilitation medic in her experience. Okay, thank you very much, Emily, for your time, for your presentations, and your answer all the questions, not all the questions on tonight, but we will try to make an email and we will try to send to you. Well, thank you very much. Before we continue with the next sessions, we have wheel of name, but unfortunately we will not do wheel of name, but we will give for the 5 persons who has asked the questions: Dr. Fauzia, Dr. Sheila, and Dr. Sri Suharti, Dr. Sukma, and Dr. Agustri. We will give you our product, Yokalmo, and also Eurospira, one of them. So this is our products, and just use our product and just give us the feedback or give us the testimony about our products. Okay, thank you very much for your attention, guys. Thank you very much for your time. Before we close these sessions, I will give back this time and screens to MC. I will give you back Dr. Zidan. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.